MedEsthetics. We have some more people signing on, so we're going to get started in just about 2 minutes. Hi, everyone. Thank you so much for joining us. This is Inga Hansen again at MedEsthetics. We have a few more people still coming on, so we're going to get started in just a moment. Hello, this is Inga Hansen at MedEsthetics. Thank you so much for joining us. We're going to go ahead and get started. If you have any questions at all during the webinar, you can type them into the question box on the right-hand side of your screen, and we will answer them at the end of the presentation. Today we'll be looking at the role of the skin's master cells in aging and talking about anti-aging skincare actives such as retinols and growth factors, and also learning about the results of a multi-center clinical study on the new Age-Repair Defensins, a new active ingredient for skin aging. Our presenter is dermatologist Amy Forman Taub, MD. She is the founder of Advanced Dermatology and Skimpo Specialty Skincare Boutique in Lincolnshire and Glencoe, Illinois. Dr. Taub is a clinical and cosmetic dermatologist and served as principal investigator of the multi-center placebo-controlled clinical trial on Age-Repair Defensins. Welcome, Dr. Taub.
Thank you, Inga. Thank you so much. So we're going to get started. We're going to talk about stem cells in dermatology, and hopefully we'll be able to show you how we might be able to naturally turn the clock back in our skin. Here are my disclosures. It's a busy slide, but I am an investigator for Medicell Technologies, which owns the rights to DefenAge, and I have a very, very small piece of equity in that company. Let's talk about first what the major human stem cell types are. There are something called pluripotent stem cells, and these are embryonic stem cells, and those are present in the very first stages of life when we're just a small ball of cells. There are also something called induced pluripotent stem cells, which are in the lab, and also stem cells that can be cloned, but also in the lab. There's also fetal and birth-associated stem cells. There's neural stem cells, placental and umbilical cord stem cells, and other stem cells. And then there's adult stem cells. We're going to be focusing mainly on those that have to do with the skin, and those are basal stem cells, hair follicle stem cells, and mesenchymal stem cells. So when we look at the pluripotent and the fetal and birth-associated stem cells, the main applications of these are injectable drugs. After all, these are actual living cells. Whether they are extracted from a human being or they're created in the lab, these are living cells. Whereas adult stem cells have been harvested and used for injectable drugs, and also they're targets for stimulation. So instead of actually taking a stem cell out of a human and using it either for what's inside of it or to inject it back. We can also use it as a target to stimulate it when it's actually in place in the body. With the pluripotent stem cells and the fetal and birth-associated stem cells, there are a host of regulatory issues. These are somewhat, somewhat political even in their origin. There's ethical issues. There are genetic instability issues. There's infection risk. There's tumorigenic issues. And most of these are 5 to 10 years from the lab research to the clinic. In other words, they usually follow a regulatory pathway through the FDA that would be similar to a drug. Whereas with the adult stem cells, some of these are already in use, mainly because you could extract stem cells from a person and inject them back into that same person without much risk. Obviously, if you did that into other people, there are risks. But if you use it as a target for stimulation, as we're going to talk about, in a topical agent, there's very little risk, and you can develop this quickly. So let's talk about what a stem cell's job is. The main jobs of the stem cells are for maintenance. So when you have an exhausted cell in a tissue or organ, or they die, you want to replace them. So the basal stem cells are constantly replacing and producing new keratinocytes. And then there's trauma repair. When you have actual trauma to the skin, you create a hole, a cut, a burn, a scrape, and you need then to actually create new skin quickly. And that is where our hair follicle stem cells come in, because these are stimulated to create cells that will fill in the hole quickly. Adipose stem cells, or fat stem cells, are not dermatologic stem cells in the sense that they're not from the actual skin, but they can be used for aesthetic and dermatologic applications, and they are being used. So they are valuable tools to address dermatologic and aesthetic conditions. There are a long list of potential applications, but they're not the center of the focus of our presentation. However, we wanted to highlight that adipose stem cells are powerful tools, but they should be considered a drug with potential side effects. But let's talk about the dermatologic stem cells that are confined to the skin. Basal stem cells make new keratinocytes, and there are actually 10 types of hair follicle stem cells. Above the bulge, they're involved in skin homeostasis and repair. At the bulge, they're involved in hair growth. And LGR6 positive cells are involved in repairing the epidermis. The key cells there are the LGR6 positive stem cells. These are what we call the skin's master stem cells. That's because if you take away the skin, you can replace the skin with new cells created by hair follicles. That's why we always say that the face heals better than any other part of the body, because as we know, there's many more organelles, many more hair follicles, and many more glands. And if we have to heal from the bottom up, as opposed from side to side, we still do have a reservoir of where we can make new stem cells, or I'm sorry, new cells from these stem cells. So these cells produce all our skin during development, and right after birth, they are preserved in the isthmus zone of the hair follicle, and they remain completely dormant until they're activated during wound healing. So as you can see, below the bulge is hair growths involved cells, and at the bulge is mainly the skin repair, and then above it is also some skin repair. So what are the contributions of these hair follicle stem cells to the wound epidermis? Well, in the peri-wound hair follicle is where these stem cells originate. And when the skin is wounded, what happens is these are activated, and they can make interfollicular stem cells that go on to become what we call KRT15 positive progeny. These are transient, but they do help in the initial stages. The LGR6 positive and the GLI1 positive progeny are the long-lasting cells. They stay around, and they're going to continue to make new epidermis. The LGR1 progeny are also long-lasting, and the IFE stem cell progenies are long-lasting. If we look at the contribution of the hair follicle stem cells to the wound epidermis, it's mainly the LGR1 positive and the LGR6 positive that have the longer lasting effect. But these KRT15 positive do help in the early stages. And again, this is just to show more in the cartoon version that you can see that the LGR6 positive and the GLI1 progeny are what really make the long-lasting contributions. So there's a lot of clinical trials also of stem cell-based therapy for venous ulcers, diabetic foot ulcers, and pressure ulcers. And this is just to show that, again, obviously these are wounds that are non-healing. And so if we add some of these either stem cells or products that improve the healing with by stimulating stem cells, we might be able to get these wounds to heal. So let's talk about wound healing and how we create new keratinocytes. What actually happens in wound healing is that neutrophils are activated, and they're part of our immune system. And they release molecules called defensins. And these defensins actually act directly on the LGR6 positive stem cells. And now these LGR6 positive stem cells that have been activated create new basal stem cells, and then they fill in the wound with new keratinocytes. These newly created basal stem cells produce fresh keratinocytes for the rest of our life. What does that mean? What that means is these stem cells lay dormant and are only activated during wounding. So these have not been subject to many mutations or aging because they've basically really not been around. They're just sitting there dormant. What are defensins? Defensins are messaging peptides. Defensins message LGR6 positive stem cells to wake up and to build new basal stem cells. As we talked about, they are sleeping until a wound. Defensins are released by neutrophil in wounds. Defensins are peptides but not growth factors. So if you look at this schematic, peptides is like they're basically fragments of proteins, and those can be broken down into either cytokines, which are secreted glycoproteins that are secreted by cells. And amongst cytokines, there's growth factors. We know what those are, like fibroblast growth factor, epidermal growth factor, TGF-beta growth factor, etc. There's also interleukins. Those are types of cytokines. Interleukin 6, 8, 10, and many others. On the other side of peptides are what we call antimicrobial peptides. They actually have some activity against bacteria and other microbes. And in that category is defensins, which are called cysteine-rich peptides. And there's alpha defensins, and there's also beta defensins. This basic science paper is actually what led MedEsthetics Technologies to look at defensins as an anti-aging skincare product. In this project, they looked at stimulating the follicular bulge, which is the LGR5 positive and LGR6 positive stem cells. And they used gut-derived human alpha defensin. So they extracted it from the gut. And they showed that it resulted in a decreased bacterial presence, enhanced wound healing, and hair growth from tissues devoid of adnexal structures. So here in the upper left-hand corner, you can see this was the wound on day 0, both day zeros. At day 10, nothing was done to heal this wound, and that is how it looked on its own. However, this defensin, alpha defensins, were applied to this wound daily, and as you can see, at day 10, the wound healed completely. And this is the graph to show you that that was statistically significant, and this is the wound healing with the alpha defensin 5 added. So LGR6 positive cells can recreate an entire epidermis. And these stem cells are able to undergo proliferation, differentiation, and migration, following seeding onto a variety of collagen-based scaffolding. In addition, deployment of these constructs induces epithelialization, hair growth, and angiogenesis within wound beds. This is the reference for that. So what about retinol or other anti-aging processes or skincare products? We picked retinol because we know that retinol does stimulate epidermal turnover. And what is the difference besides the chemical differences? Well, a big difference is that keratinocytes stimulate the already existing basal stem cells to create new keratinocytes. So you can think about your basal stem cells, and they're old. They're as old as your keratinocytes. So if you're 50, your keratinocytes are 50, and your basal stem cells are 50. Whereas defensins, what they do is they stimulate these stem cells that have been inactive. So they're sleeping. So they haven't been subject to as many of the aging things that have occurred. They haven't gotten as much environmental damage, ultraviolet damage, pollutant damage. They haven't been subject to as many mutations. We can't say they don't have any, but they haven't been subject to as many mutations. So when they create new cells, these are completely what we call fresh cells. And these are going to make fresher keratinocytes. Hopefully keratinocytes that are much more like our youthful keratinocytes that we had in our younger years, because these cells are dormant and they're making something that's completely not mutated. What happens to our cells as we age? Basal stem cells highly proliferate during life. So we're talking about stem cells that are there in the basal layer of our epidermis. They acquire a lot of damage and mutation from photodamage, and they become old and quote-unquote exhausted by these acquired mutation. Whereas LGR6 positive stem cells, they stay dormant during life. They occasionally proliferate, but only when we need them, for instance, when we have wound healing. So without a wound, they don't come to actually be active. They acquire minimal number of mutations compared to proliferating cells, and they produce new and fresh cells during wound healing because they're less damaged. The acquired damages that we are exposed to in life cause multiple reductions of skin cell functions. In terms of keratinocytes, we know that they have less proliferation and differentiation, low cell signaling and growth factor response, and low barrier function. So when we try to stimulate these older keratinocytes, they already are reduced in their function. Melanocytes are lower in number, and they have a lower lifespan and growth factor responses. Langerhans cells, which are important for immune function, are lower in number. They have morphological abnormalities, and they have lower cutaneous immune function. And fibroblasts are also lower in number and have lower lower responses to growth factor stimulation. So old basal cell stem cells make old keratinocytes, whereas young basal stem cells make actively functioning keratinocytes. And so you can see in the insert on the left side, photo-age skin, which doesn't have as well differentiated cells. You don't see the tight junctions as well. And whereas in younger skin, you can really see each individual cell, and you can see the healthiness of it. And that is going to be the difference between what we can create by stimulating these older stem cells to make newer epidermis, as opposed to making brand new basal stem cells that can create a more healthy epidermis. So let's talk about the 4 generations of what we call quote-unquote stem cell skincare, okay? Really, the first quote-unquote stem cells were extracted from apple and plant cells. And this was an undefined mixture of active molecules or growth factors. We don't really know what was in it. It switches on quote-unquote everything. In other words, it's not targeted. They're not really from stem cells. It has low efficacy and it forces older stem cells to work even harder. But you know what? It was good in its day because we didn't have anything like that. So there was some efficacy. That's kind of like when we had things like, you know, the plant-based growth factors. I'm sorry, I'm blocking on the names of them right now. And then we got conditioned medium growth factors. These were extracted from skin cells that were young, that produced a supernatant of a soup, basically, of growth factors. Again, this is non-specific, can switch on everything. And there's some controversy over whether TGF-beta is a cancer trigger or not. And in addition, don't forget that these growth factors are going to be stimulating older keratinocytes. So we're going to force our older cells to work harder than ever before, and you might get some improvement from that, and you do get some improvement from that, but it may not be as ideal as we would like it. The next generation is a more defined peptide, and there's specific peptides, the combinations of peptides, but these are either non-specific or specific, but they still don't actually stimulate the growth. They can stimulate growth factors, but the end result is that they stimulate older keratinocytes or older fibroblasts to work. They still can't get to the LGR6 positive stem cell. And this is what we call the fourth generation, which is the peptide defensin is activating a specific stem cell. It's very focal to create these new skin cells. I kind of compare this to what's happening in other areas in like medical dermatology. For instance, in psoriasis, when initially we had, for instance, methotrexate or cyclosporin, we kind of learned from that psoriasis was an autoimmune disease. But what did that do? That turned off the whole immune system, or it reduced our immune function. Well, that was good, but it had a lot of potential side effects. Methotrexate wasn't so effective, but cyclosporin, I don't know how many of you use it for psoriasis, it's extremely effective, but it really creates a broad and diffuse reduction of our immune system, and it also has some other side effects. So then along came things like biologics, and now we are focusing, I mean, we've got an explosion of those drugs, and each one is targeting a different factor in the pathway, the molecular pathway that causes psoriasis. So we're trying to get more and more focal pathway, and the reason for that is the more focused we can get it, the less side effects we might have. Well, the same thing with this is the more focused we can get it, the more specific we can get it, maybe not only the better it is, but also we don't have any extraneous things happening, and certainly we don't want to turn on cells that are going to be activated that potentially have mutations. The initial study that was done by Dr. Greg Keller. He's a he's a plastic surgeon in Santa Barbara, California. Has a great interest in skincare and also in stem cells. And he used the original synthetic alpha defensin 5 and beta defensin 3 in a cosmetic base, which is what we're talking about. He did a study for 6 weeks. He used a system called Quantificare, which can objectify some of the parameters that we look at, as opposed to just looking at before and after pictures or even subjects. And there were a total of 22 men and women. So this was the pilot study. They were 47 to 68 years old. The average was 56. And there were skin types 2 to 4. And there was an improvement in the wrinkles and in oiliness, which was a little bit of a surprise, as you can see in the graphs afterwards. And here's a representative photograph of a patient before and after. And I think that you can see that the wrinkles were better and that the skin is a little brighter. And from the same study, there was an open-label, double-blinded study, and the photos have not been retouched. You can see on the left around the eyes before and after 6 weeks, and also around the jawline with smile lines and some wrinkles in the neck before and after 4 weeks. One of the nice things about this product is it does work pretty rapidly. So after the positive results of this pilot study, we endeavored to do a formal study, a multi-center placebo-controlled double-blinded IRB-approved study. There were 3 sites, myself, I was the PI, Vivian Bouquet, and Gregory Keller. The time points were baseline, 6 weeks and 12 weeks. There were 45 participants. They were all female. There were 14 to 16 participants per clinical site. 1/3 of them had placebo. Placebo was represented by the exact same product minus the actives, and they were in the exact same bottle. So it was a true sham. It was not like a different cream. And two out of 3 had full formula, and they were on average 60 years old with a span of 41 to 71. We had many evaluation tools. We tried to do as much evaluation as we could. There was the clinical Griffiths scale, which is basically the 3 investigators looking at the patients and grading them on the Griffiths scale, which is a well-known clinical scale, and all participants underwent this. There was histology performed with also immunohistochemistry on 7 participants, so biopsies. High-resolution skin ultrasound and multi-parameter skin testing. This again was the Quantificare, which was performed at Gregory Keller's site, 15 participants. Also, they underwent a 3-dimensional skin imaging and skincare scores and population analysis, which is something called Pores. And higher resolution clinical photography was performed by all sites. The tested regimen was a 3-product regimen, which is this DefenAge serum, cream, and mask. The cream and serum are supplemented with alpha defensin 5 and beta defensin 3, which are the main actives. The mask is 1 or 2 times a week, which is basically just an enzyme exfoliant. The cream and serum are 2 times daily. The cream is applied before the serum because it has a lower concentration of the defensins, and I'll explain that in a minute. And that was used for 12 weeks to the face, post-auricular area, and the neck. The placebo group, as I mentioned, received the identically packaged regimen without the active ingredients, and it was double-blinded, so neither the patients or the participants nor the investigators knew who received what. And they also received the same cleansers and sunscreens, which were sensitive skin cleanser and a commercially available sunscreen, but they all had the same one, which had a zinc oxide in it. So again, we're going to review this science again. The immune peptide alpha defensin 5 activates the dormant LGR6 positive stem cells to create a new basal stem cell, then in turn creates a new epidermis. This is some science we haven't looked at. We're going to look at this. This is tight junctions. So we know that tight junctions between the epidermal cells are important for skin barrier function. So if you look at this study that was in the JID, an antimicrobial peptide, again, the human beta defensin 3, it improves the function of epithelial tight junction barrier in human keratinocytes. And on the left, you can see the placebo. And on the right, you can see the beta defensin 3 treated skin and the bright birefringent red that indicates that the tight junctions are very active and healthy. This is actually why we use the cream before the serum. The cream has some antioxidants in it and other things to improve the anti-aging, but it has much less beta defensin 3 and alpha defensin 5 than the serum, and the activity of this beta defensin 3 is really, really rapid. So we don't want to put the serum on first and have the tight junctions all like shut. Then we wouldn't probably get much penetration of the cream. So it's a little backwards. Most people use serums before creams, and here you use the cream, which is really more of a lotion before the serum. So the evaluable endpoints in the study were epidermal thickness and dermal thickness, immunohistochemistry, which I'll explain, which is a marker for proliferating cells called Ki67, and the Griffith clinical scale, which was fine and deep wrinkles, pores, radiance, and turgor. And we're going to review then the epidermal thickness. So 7 people had a biopsy, and formal histology was performed by Dr. Merrigan, a well-known histopathologist, and he measured the thickness of the epidermis in both placebo groups and the full formula group. And as you can see by this graph, the full formula group did have a thicker epidermis after than at baseline, whereas the placebo group did not have a thicker epidermis. The thickness of the epidermis measured on histology samples collected after 6 or 12 weeks of treatment, and this was statistically significant at a level of 0.003. And the average increase in thickness was on the order of about, sorry, 1 second. It was on the order of about 1.5 millimeters, or about 15 microns. So here's a dermatopathology specimen on the left, specimen from participant 4. Baseline is above 10x initial magnification, and then on the right is after 6 weeks. I think you can appreciate a thicker epidermis and also more organization of cells. There's just more cells. And then on the left lower, we're going to focus in on that one area, and on the right lower is again 6 weeks after, where you can just see an overall thickness of the area. There's also, it's important to note, no inflammation or change in inflammation status in any subjects who use the full formula regimen, and because of that, we came to the conclusion that the mechanism of epidermal thickening was not inflammation. This is participant 4 again, just showing you the close-up before and after of the thickness of the epidermis and the lack of inflammation. And this is another patient, participant 10. Again, this is zoomed out. Here, we're going to look at this a little closer up, and I think you can see more reedy pegs and more cells with thicker epidermis and more definition of the cells. Again, a little bit more zoomed in just to see that this just looks healthier than this, and again, pretty much a lack of inflammation. That was baseline versus 12 weeks. So the full formula regimen led to an increase in epidermal thickness without visible signs of inflammation. Why is that important? Because we know whenever we get inflammation of the skin, we can get an increase in epidermal thickness. That's part of the way that retinols work, but we don't want to get inflammation. We want to actually be completely non-inflammatory. We don't want to really increase the number of proliferating cells either, because we want to not proliferate cells that could be mutated. So one other parameter we looked at was immunohistochemistry. This was done by staining of the tissue that Dr. Merrigan performed, and he looked at the Ki-67, and Ki-67 is a good sign of proliferation. It is shown that Ki-67 positive cells are increased in various forms of cancer, including squamous cell carcinoma, also other kinds of cancer like breast carcinoma. That doesn't mean that normal tissue don't have any Ki-67, but we would not want to see that increasing. And we did not. We saw in the placebo, there was a slight increase. It was not statistically significant. And in the formula, we also saw a slight increase, and it was not statistically significant. And although this doesn't absolutely prove that we're not increasing carcinogenic mutation cells to proliferate, it's certainly very reassuring. What about the Griffiths scale evaluation? Baseline versus 12 weeks. And all of the participants, 31 participants that had full formula, saw improvement. And across the board, it was statistically significant down to 1 in 10,000, which was highly statistically significant, whereas in placebo, there was no improvement at the level of P was greater than 0.05. We saw the same for superficial wrinkles at the same level. Again, in the placebo group, no improvement. And for deep wrinkles, we saw an improvement at that same level and no improvement, this p-value. So 1 in 10,000, so basically, based on chance, there would only be a 1 in 10,000 chance that we could see this kind of a result of pores, superficial wrinkles, and deep wrinkles, that it could be ascribed to chance. So we're going to look at pores from a different point of view now with the quantificator system. So quantificator works by comparing these pores to a database of people that they have. So a +2 is an excellent skin condition and a -2 is a poor skin condition. So when we started out, if we look at the 0, we started out with better skin than typical. It was at 1, a little bit over 1 in the placebo group. But at 6 weeks, it was a little over 1, meaning it was a little better than what their group saw in terms of pores. And after 12 weeks, that diminished a little bit, but certainly nothing major. So in essence, it didn't change. For whatever reason, the full formula group, we started out with a little coarser skin. It was a little less than 1. And then at 6 weeks, it went up to 1. And after 12 weeks, it went to about 1.5. And this was statistically significant at a level of 0.01. And here's a picture showing an enhancement where blue represents the deepest pore, red represents an intermediate pore, and yellow is a more superficial pore. And this is one of our patients at baseline, before treatment and after treatment with full formula. So you can really see a very visual example of how well it did with pores. It's a very unexpected finding, actually. And this is a close-up just to show this participant. In terms of improvement of skin oiliness, again, back to the scale where 0 is kind of baseline for their group. But again, the baseline level of our placebo group was a little better than average. It kind of diminished over 12 weeks. So in other words, it went from being a little less oily than their average to a little more oily, but not statistically significant, whereas in the full formula group, they went from being, again, a little better than their average. 6 weeks, not very much of a difference, but at 12 weeks, we saw a statistically significant improvement in oiliness to the level of 0.01 statistical significance. And we have a visual on the wrinkle reduction. This is at baseline, and then after full formula, we can see intermediate depth wrinkles in the forehead that were vastly improved at 6 weeks. So this is something called Cortex, and this is another fancy type of measuring tool that Dr. Keller has in his office. It's a high-resolution skin ultrasound, which can demonstrate dermal thickness. And these are the best subjects with the best results. So if you look at this, the dermis is highlighted in red. Above is the unfiltered image. Here is the epidermis. You can see my pointer. And here's the dermis. And the dermis at baseline in this particular patient measured 1.42 millimeters. At 6 weeks, again, unchanged picture. Here at 6 weeks, it was 1.764 millimeters, and at 12 weeks, it was 2.001 millimeters. So it gained a 0.6 millimeter improvement in the dermis, and this was participant 18 full formula. And this is not the same participant, but this is a participant 10 who had full formula. And I think you can see an improvement in the dermis. There's thicker, better aligned collagen, and it stains more. but I do want to emphasize that that did not necessarily reach statistical significance, but there was a trend. And this is a clinical example of before in 6 weeks. I think you can see, somebody who's very globally damaged and a global improvement in the radiance of the skin and in the depth of the wrinkles and overall wrinkles. I think you can see here around the eyes a significant reduction in the depth of the wrinkles and a significant reduction here and even around the lips. And just improved turgor. And this is just a close-up of the area around the eyes. And this is another way of looking at the wrinkles. Baseline at 6 weeks, three-dimensional image, so that you can see how it looks from different angles. So let's talk about transepidermal water loss, which was measured by this quantificator. It actually measured the this is from Dermalab Skin Lab Combo, which is the Cortex technology, which is from Denmark. It's shown as water loss in grams per square meter of skin per hour, and the data represents the average per group. So in the placebo group at baseline, this was the water loss. At 6 weeks, it was a little improved in the placebo group, and at 12 weeks, it was a little more. But none of that was statistically significant, whereas at baseline here in the full formula group, there was a marked improvement in 6 weeks, which fell off a little bit at 12 weeks, but this was statistically significant improvement in the transepidermal water loss, which was reduced. And then another measure of the skin's hydration, another way of looking at hydration, was also measured by this Dermalab Skin Lab Combo. The skin's hydration was estimated based on conducting properties of the upper layer of the skin, and again, the data represents the average per group. In the full formula, there was little difference, whereas in the placebo group, there was little difference, whereas in baseline, there was a marked difference, although it did not achieve statistical significance. In terms of elasticity or retraction time, in the placebo group, the retraction time actually worsened. You want the shortest time for retraction, so it snaps back. In the full formula group, we did see improvement, and although it looks like there should be statistical significance, there was not. And in dermal elastosis, going back to this ultrasound image, these are the two participants with the best results. You can look at this evaluation based on the appearance of the subepidermic low echogenic band. If you look here where the epidermis is and you look in this area, this is called the low echogenic band. So the less echogenicity, the fewer structures are in there. I think you can see that after 6 weeks in the full formula participant, we're seeing more activity in here, and also in participant 23, a lot of empty space before and less empty space afterwards. In terms of skin evenness, which is really more a measure of texture, and again, back to this population base where 0 is the average participant. We started out better than the average participant and pretty much stayed the same in the placebo group, whereas in the full formula group, the evenness of the skin improved at 12 weeks at a level of 0.002. And also skin color, melanin, we see that in baseline and 6 weeks in the placebo group, there was no change, whereas in the full formula group, the melanin was reduced at P002, 0.002. And again, this was done using the quantificator imaging, which is more objective. So in conclusion, regarding the skincare regimen containing the alpha and beta defensin 3 and 5, we think that we've pretty convincingly shown that there's a lot of significant findings. Epidermal thickness was increased in the absence of excessive proliferation or inflammation. Pores were reduced as well as oiliness. Fine and coarse wrinkles were reduced. Evenness of the skin or texture was improved. Transepidermal water loss was decreased. Skin pigmentation or melanin was reduced. And there were trends without statistical significance, and this was improved elasticity and turgor and increased dermal thickness. So in conclusion, we feel that the messaging peptides, alpha and beta defensin containing skincare regimen does globally improve the sign of skin aging after a pretty rigorous study. Thank you. We're going to open it now for questions.
Yes, and thank you so much, Dr. Taub. And we do have some questions coming in. If anyone has some questions they haven't sent over, please feel free to type those in. And one person is asking, how is turning on the LGR6 with defensins different than the wound healing response you elicit with microneedling?
Okay, so that is a good question. And I'm not sure. I'm just going to be completely honest. I'm not sure if microneedling turns on the LGR6 positive, because don't forget that there's also a lack of inflammation with microneedling. So really you have to kind of think about this. Generally speaking, it's neutrophils that release defensins. Neutrophils are white cells. So there's inflammatory processes going on when you stimulate neutrophils. So I think one of the hallmarks of microneedling is not to stimulate the wound healing cascade, because you don't want that inflammation. And so I think they pride themselves, or my understanding of it is that when you don't have the heating, you don't actually have wounding. You don't stimulate that inflammatory cascade, which would then create neutrophils, white cells, and other kinds of things that could potentially cause scarring. Now, in this case, remember, we're just taking that one molecule and we're isolating it. We're saying that is what is really turning on the LGR6 positive cell. When a neutrophil is activated, many cytokines are secreted, not just the LGR6 positive alpha defensin, beta defensin 3 activators. So I think that I can't say for sure, but I think that if you look at the pathways, you would find that that does not release defensins, because you are not stimulating a neutrophilic type of inflammatory wound.
Great. And somebody else had a question wondering if the DefenAge can penetrate if you have someone who's using retinol and antioxidants.
Yes. The answer is yes. It can penetrate with or without retinol and antioxidants. It's a fairly small molecule.
Okay, great. And can you use this after things like laser and chemical peels and microneedling, or should it be done on healed skin?
Well, it's a good question. I mean, we don't really know. There is some controversy about using, especially after microneedling. I'm going to address that first. Or laser resurfacing that's ablative. When you have laser resurfacing or ablative or microneedling, you've actually created a channel through to the dermis. Okay? So, if we could say we had sterile defensins and nothing else in the product, then I would say yes. But there are people who are using it after microneedling, but I would still use caution because of the fact that, first of all, the product is not sterile. I mean, that doesn't mean it's contaminated with bacteria, but it's not sterile. Second of all, there's other ingredients in it. You know, there's excipients to make it, flow. So there's ingredients that make it a gel. There's ingredients that make it a cream. There have been instances where people have used things that have been microneedling, and it could create an inflammatory process because of the other ingredients. So if we could get pure alpha defensin 5 and alpha defensin 3, then I would say yes. I would love to say yes, and I would love to do a study and I think there are some studies ongoing using the DefenAge serum. I probably would not use the cream, or the mask for that matter. But at this time, I can't really tell you that it's safe to do. So I would wait whatever the time is that you think that there's some epithelialization, and then I would use the DefenAge after that. Now I can tell you anecdotally that I use, this comes in a one-day kit, and in that one-day kit there's like some serum, a thing of serum, and I've been using it for patients that have, shall I say, areas that are difficult to heal or wounds that are difficult to heal. I've been using it on sutured skin and like shaved skin in people that have, difficulties healing wounds, and also in areas like the lower legs where wounds don't heal well. And anecdotally, I believe that it has helped the wound healing, and I've not had a problem with that. But I just, I can't really say for sure, and so I'm always going to be cautious with that. Mm-hmm. In terms of other lasers, like non-ablative lasers, you don't have those channels, so it's fine to use on the skin, and certainly if you wounded the skin. And certainly it's fine to use on any non-ablative, after any non-ablative laser treatment.
And there was another question asking, is this something that you would cycle on and off like retinoid, like use quarterly, or is this a daily long-term routine?
Well, I don't think you need to cycle. I'm not sure why you would cycle on and off retinol either, except for the fact that it irritates the skin. You may get to a plateau, where the skin isn't improving anymore, and we really don't know where that plateau would be and how long it would take for the skin to fall back to its old ways. So again, you'd need to do a long-term study to see at what point, is it 3 months, is it 6 months, is it a year, where the skin has gotten as good as it possibly can get with the skincare regimen, and then withdraw it from the skin. That would be a very hard study to do. So the answer is we don't have any, we don't have any data on that. Personally, I would think that, you'd kind of want to continue it because the results are good. But speculating.
So you don't need to pause your other skincare routine. You could add this in potentially?
No, you do not need to pause it. I mean, I recommend, yes, go ahead. I mean, I usually recommend that people use an antioxidant, something that's going to stimulate, keratinocyte growth, such as this, a zinc oxide-based sunscreen, and something that exfoliates a little. It just so happens that the DefenAge kit comes with the moisturizer, which has antioxidants in it, and the serum and moisturizer has the defensins, and then the mask is meant to kind of try to give you a little bit of exfoliation to stimulate increased metabolism. So it's kind of a complete regimen without the sunscreen. You need sunscreen, obviously. But you can mix and match if you want. I mean, this testing was done with a full kit. So we don't know if you use your own antioxidants and use your own type of exfoliating, if you would get the same results by just using the serum. But the serum has the most active defensin ingredients in it.
And are there any colors or perfumes in the DefenAge products?
No.
And now, are the defensins in this, these are synthetic versus human-derived?
That is correct. They are synthetic. So it's a copy. And again, to go back to some other, like an example, okay? Kybella. Okay, Kybella is an exact copy of I'm sorry, I'm blocking on the name of it, but it's, it basically breaks down the fat in our system. It's released by our gallbladder to break down the fat that comes through our digestive system. It's an exact replica. And this is a replica made to be exactly like human defensin 5 and 3, but they're copies. So they were not extracted from tissues or anything like that.
And somebody is asking, is it okay to put this product on the upper eyelids?
Well, again, we don't, we don't really know. They are coming out with an eye cream. I don't know if they're going to test it on the upper eye. Again, it's like you can't really say because we haven't tested it. So buyer beware. Again, I would probably use the serum because it has the least amount of other ingredients that could be irritating. But generally speaking, unless something's been tested, I don't usually recommend my patients to use it on the upper eyelid. The lower eyelid is usually fair game, and the main reason is because we all know that it can, seep into the eye when we're not looking, when we're sleeping, whatever, and we don't know how it's going to act there.
And now another attendee is asking how DefenAge is used in conjunction with PDT. Is that something you're doing?
Again, just like any other procedure, you could use it post-procedure because PDT doesn't actually, break the surface of the skin, so to speak. Yes, they exfoliate, but we're not talking about making a channel, so certainly you could use it after PDT. I mean, I think it's a great idea.
And somebody else was asking, and I'm not sure if this is a question for you, but whether these products are available to estheticians or if these are only for physician dispensing.
I think you'd have to ask the company, but as far as I know, they're only available to physicians.
Okay. And now we got a question that says, due to the fact that defensins help with transepidermal water loss, do they also help other molecules like vitamin C, retinol, super antioxidants lock into the cellular level? Like, do they improve the efficacy of other actives?
Well, it's actually a tough question. So if you put on the serum, you should put it on last. I'm talking about the defensin serum. Because remember what I said, the tight junctions kind of seal up pretty quickly. So if you were to put on the serum and then put on your vitamin C, it actually might not get in. But if you put it on at a different time or you put it on first, then yes, you would be locking it in. So it's a little bit of a tricky question, but I think that overall, yes, because you're going to be losing less, and the skin is going to be thicker, so you're going to have more for the vitamin C to work on. But I don't know about this idea of locking it in. I'm not sure. But you'd put your other serums on first.
And this is another one that might not be a question for you, although you're sure, but they're wondering how much do the products cost in terms of to the practice and what you retail them for?
Actually, is my screen still up?
Yes.
Can you, let's see, hang on. I mean, I guess if I'm allowed to tell, I will say, hang on. I can look at, I don't really know off the top of my head, but I'm going to look.
Is it pretty similar to other
Yes, it's similar. I mean, it's in, like, I think it's, the kit is...
If I may interject,
yes.
is that okay, Dr. Taub? I have
yes.
it up.
Okay.
Sure. Yeah, BioSerum retails for $1.5. The Clinical Power Trio, which includes the serum, the mask, and also the cream, retails for $285.
So the complete kit is $285.
Correct. And they also make a travel kit as well.
Okay, and one of the things, a travel kit is really great. They have a travel kit for people who travel a lot. They also have this one-day kit because, you know, it's hard sometimes to get people to buy things that are $265, but you are getting 3 products for that, not just one. But the other thing is sometimes they'll try it. They'll buy the one-day kit, which is only like $15. And then they'll say, you know, I like this. So it's kind of like a way to get people to try it. And it actually lasts for more than one day. But the other thing I was going to say is that the company's done something very smart, which I really appreciate. They actually have it available on their website, but it's significantly more expensive. So the patient is kind of encouraged to buy it from the doctor. So when they go on the website, I don't exactly know what they sell it for, but it's 10 or 20% more, maybe 15 to 20% more. But they sell it to you at a lower cost, and so when you sell it, you're still getting the profit. But they just they marked it up on their website so people wouldn't buy it from them. But people could still buy it. So you can tell them, hey, if you buy it from me, it's less expensive than when you buy it online, which is the opposite of what most products are. I thought that was a really, really fun twist and a way to, to help out physicians.
Great. And we actually are out of time at this point. We have someone who had some questions about the early part of the presentation, so I do want to let everyone know that this will be available on our website at medestheticsmagazine.com/webinar. So if you want to review any information or share this with anyone, you will be able to get to that within a day or two. And Dr. Taub, thank you so much again. This was a really great presentation.
No problem.